topic I'm going to present today is the anterior glenohumeral dislocation. Some objectives are the students will understand the principles and concepts of glenohumeral joint and anterior shoulder dislocation. They will understand the cause of this injury. They will know the clinical manifestations and the functional limitations with a shoulder dislocation. They will learn about the tested measurements to diagnose this kind of injury, and also about the differential diagnosis between anterior shoulder dislocation and anterior shoulder instability. Students will be able to understand the elements and phases of rehab process for this type of injury. So we already know that the shoulder is a ball and socket type of synovial joint. The shoulder is monoaxial, biaxial, and triaxial. Do we know what that means? It means that permits movement in 1, 2, 3 planes. With this movement allowed movement around the 3 axes, we can get some flexion, extension, abduction, adduction, medial and lateral rotation. And the main muscles that produces these actions on the shoulder are the rotator cuff muscles. I don't know if you all remember about Dr. Dunlap saying the acronym for remembering that, which is the SIDS, which is supraspinatus, infraspinatus, teres major, and subscapularis. So because of its freedom of movement, the glenohumeral joint is commonly dislocated by indirect and direct injury. So what is a dislocation? It is defined as a complete separation of articular surfaces without spontaneous realignment. Typically it is a dislocated joint that must be rearticulated by special maneuver by another person or by the subject. For example, in my case, the first time I got my shoulder dislocated, it was because I locked my arm with another player, and it was my very first time, so it was really painful, and I rolled on the ground, and by the time my shoulder kept in contact with the ground, it put back on place. It was not because I was like an expert in my shoulder, but it happens just like that. And this is the most common dislocation on the shoulder. This one is also occurs most often in young adults, especially athletes. For example, it's common on throwing and racket sports, swimming, and gymnastics. It is caused by excessive extension and lateral rotation of the humerus, which means that the head of the humerus is driven anteriorly, and the fibrous layer of the joint capsule and glenoid labrum may be stripped from the anterior aspect of the glenoid cavity in the process. This may tear the capsule and dislocate the shoulder anteriorly to the infraglenoid tubercle. The flexor and abductor muscles of the glenohumeral joint usually pull the humeral head into a subcoracoid position, which means the head of the humerus is located beneath of the coracoid process of the scapula. Long story short, the head of the humerus ends up dislocated anteriorly. Some clinical manifestations and functional limitations are pain, inflammation, numbness, weakness, and bruising. Some patients usually report a pop or tingling in their arm, or the sense that the shoulder is out. Some activity limitation that some patients may go through are inability to perform sports activities, overhead serving, swimming, and daily activities like getting dressed, eating, brushing their hair. Most likely these activities will involve humeral elevation. And this is caused because of the limitation of the range of motion on the shoulder, the decrease of muscle strength, and the decrease of endurance on the rotator cuff muscles. So tested measures, the x-rays are used to confirm the dislocation, and according to our books for anatomy and ortho, CT and MRI scans can help to check if there's any injury on the axillary nerve, because it can get damaged with this kind of condition. Also, we can do some MMT of the shoulder, which is abduction and flexion, because it involves the deltoid muscle, which also helps to test the function of the axillary nerve. Now, the crank, apprehension, relocation, and modified relocation tests all are performed on supine. For the crank test, the arm of the patient is elevated 160 degrees in scaption and is positioned in maximal internal or external rotation. The clinician will apply resistance along the humerus. A positive test is indicated by the reproduction of a painful plate on the shoulder. The apprehension test, they position the arm at 90 degrees of abduction and full external rotation, and the clinician will hold the patient's wrist on one hand, and with the other one will stabilize the elbow. And the clinician will apply pressure into external rotation, and patient's apprehension from this maneuver rather than pain will be a positive test. Then the relocation and the modified relocation test, the only difference is that for the relocation test the arm is positioned at 90 degrees, and for the modified one, it's on 120 degrees. The clinician will grasp the elbow with one hand and maintain the testing position and grab the humeral head with the other hand, and they will pull the humeral head anteriorly and demonstrating pain and apprehension. It is an indication of a positive test. And also the clinician will push the humeral head posteriorly while maintaining the shoulder in the same position. That's gonna be more like the relocation, pop back in the shoulder. And of course, range of motion of the shoulder, that we already know how to perform that. And surgery that helps repairing tissue, ligaments, and tendons. For differential diagnosis, the anterior shoulder dislocation is commonly misinterpreted for inferior dislocation and posterior dislocation of the shoulder because they basically have the same symptoms and signs. The posterior dislocation is the least common dislocation of the shoulder. And this can cause some shoulder instability, and those differential diagnoses can be rotator cuff tendonitis, either acute or chronic, bicipital tendonitis, and subacromial bursitis. There's a chart that y'all can reference from the book that it shows more in depth each of the diagnoses. Now for the rehab process, we have phase number 1, which is the protection phase. We need to avoid stretching anteriorly the joint capsule, pushing into external rotation, shoulder extension, traction force of the glenohumeral joint, horizontal abduction, and for the range of motion, it needs to be pain-free, passive range of motion, and then progress to active assist range of motion, and then active range of motion. For some exercises can be submaximal isometrics, internal and external rotation, elbow flexion and extension isometrics, wall slide, supine, internal and external rotation, elbow flexion and extension in neutral for the shoulder, and also horizontal abduction and stretch. For phase 2, which is the control motion, we need to avoid lifting weight overhead. For the range of motion, it's going to be the same as phase 1 with the progressions as the symptoms outlined. Some exercises can be scapular retraction and protraction, closed chain weight shifts, open chain stability, plank progressions, lower abdominal training, standing exercises, lower extremity squat with upper extremity activities. Phase 3, that the patient will return to function. We're going to increase light therapy activities. We are going to do an active warm-up prior to the exercise and stretching. We're going to develop an individualized maintenance programs, and we're going to provide some recommendations for the patient to go back to regular activities. Some exercises is the lat pull down, chest fly, bench press, shoulder press, and therapy activities, and dynamic stabilization exercises. Some of the outcomes for phase 1 is reduce pain, inflammation, protect anterior joint capsule, minimize negative effects of immobilization, improve flexibility, range of motion, and improve muscle control. For phase 2, we need to achieve full active and passive range of motion, muscle balance, improve the muscular strength and endurance, prepare the entire body for return to activity. And for phase number 3, we don't have any pain, full shoulder motion, neuromuscular control, proper third wind mechanics, and return to activity. So, as an overview of this presentation, we already know that the glenohumeral joint is designed to allow mobility of the upper extremities, that the glenohumeral joint is a diarthrosis, which means it's a freely movable joint, and it has 3 degrees of freedom. We know that the dislocation is an injury that forces the bones in a joint out of position, and it is for the glenohumeral, anterior glenohumeral dislocation. It occurs when the shoulder is in abduction, external rotation, and extension, meaning that the humeral head is dislocated anteriorly, and the injury will limit the patient's functions and regular activities, and typically they present pain and weakness, and we need to perform some special tests so we can progress for diagnosis and rehabilitation.